Hi friends, in this video we are going to see about another obstetrical emergency, that is uterine inversion. Uterine inversion means the uterus will turn inside out. When you are removing a socks, you might have seen that it will just turn, the inner portion will become outside and another outer portion will become inside. In the same way, the fundus of the uterus will enter into the uterine cavity, that is known as the uterine inversion. Next, we can see the classification of uterine inversion. It is classified into three types according to the level of inversion, according to the degree of inversion, and according to the timing or event of inversion. It can be classified into different types. Now we are going to see the classification according to the level. First one is incomplete inversion and second one is complete inversion. If the uterus has turned inside out, but the fundus has not descended through the cervix. That is, it has turned inside out, but it has not reached up to the level of the cervix, or it has not entered into the cervix. That is known as the incomplete inversion. Complete inversion means the fundus has passed completely through the cervix to lie the vagina or lie often outside the vaginal wall. That is, the uterine fundus will turn inside out, it will pass through the cervix and it will come up to the level of the vagina. Sometimes it may come outside the vagina also. That is known as the complete inversion. Next, on the basis of the degree, we can classify the inversion into 4 degrees: first degree, second degree, third degree, and fourth degree. First degree inversion means uterus is partially turned out. Only the partial or the upper portion of the uterus or the fundus will get dimpled. Just slight depression will occur. Second degree means the fundus has passed through the cervix but not outside the vagina. It will just pass through the cervix and it will reach up to the level of the vagina. And third degree means the fundus is prolapsed outside the vagina. It will come out the vagina. And fourth degree means along with the uterus, the cervix, vagina, all those portions will come out through the introitus and it will be visible outside. So these are the 4 classification on the basis of the degree. Now let us see the classification on the basis of the timing. Here you can see the picture of the first degree. Here it has just turned inside out, but it has not reached up to the level of the cervix. Sometimes it may reach up to the level of the cervix, but it won't enter into the cervix. And here the second degree, you just see it has passed through the cervix and it has reached into the vagina. And third degree, here you just see the complete, this portion is a uterine fundus. It has come out. In the vulva, it is visible. This is the third degree. See, in this picture it is more clear. This is the first degree, only the fundus is dimpled down. Here this is the second degree, it has reached up to the cervix, and third degree it has come out. And according to the timing or event when it is occurring, it can be classified into acute, subacute and chronic. In the case of acute, it occurs within 24 hours of delivery, and in the case of subacute, it occurs within 24 hours to 4 weeks of delivery, and in chronic, it occurs after 4 weeks of delivery, or sometimes it may occur even in non-pregnant stage also. That is known as chronic. Now let us see the causes of uterine inversion. First reason is excessive traction on the umbilical cord. During the process of labor, in the normal condition, after the delivery of the baby, the placenta will get separated naturally and it will come out. But here what will happen means the placenta may remain inside, and naturally the examiner or the person who is performing the delivery will apply or may apply traction over the umbilical cord, and this traction may lead to the inversion of the uterus. And another reason is excessive application of fundal pressure. During the process of labor, in order to support the uterine contraction, if you are applying pressure over the uterine fundus per abdominally, that may lead to the inversion of the uterus. Another reason is placenta accreta. That is, in the normal cases, I have told you that within 30 minutes of the delivery, the placenta will get separated naturally without any external influence. But here the placenta will not get separated, it will get adhered to the uterine endometrium, and naturally when the examiner or when the assistant or when the nurse is trying for the separation of the placenta, there is a chance for inversion. Another reason is congenital predisposition. That is, by birth itself, some ladies may be having weakened muscles or some may be having weakened connective tissues. In these cases, there is a chance for inversion. Next is fundal implantation of the placenta. Already I have told you that in majority of the cases, the placenta will be attached to the uterine fundus. But here what will happen means, if it is attached to the placenta fundus, it is not a problem. But if you are applying traction over the attached placenta, there is a chance for inversion. And the last one is spontaneous or iatrogenic causes. That is, during the process of labor, without any external causes, all of a sudden it will occur. So now let us see what are those spontaneous or iatrogenic causes. The spontaneous causes include short umbilical cord. If the length of the umbilical cord is short, when the baby is delivering, this shortened cord may apply traction on the placenta, and that traction may get applied on the uterine fundus, so the fundus may dimple downward or come downward. In the same way, sometimes the normal length may be there for the umbilical cord, but it may or it may form certain turns around the baby's neck or baby's body. So functionally what will happen, the length of the cord may be small, and when the baby is coming down, the same pressure may get applied over the placenta, and it may get converted to or it may get applied to the uterine fundus, and that may lead to the inversion of the uterus. And another reason is sudden raise in the intra-abdominal pressure. All of a sudden, if the pressure inside the uterine cavity is increasing, for example, when the mother is coughing or when the mother is vomiting, if the pressure is increasing, that may lead to the increased abdominal pressure, and that pressure may pull the uterus downward. And another reason is morbid adherent placenta. Already I have told you about that. If the placenta is adhered very deeply, there is a chance for inversion of the uterus. And next one is Marfan syndrome or connective tissue disorder. Already previously I have told you that some people may be having a genetic disorder, that is genetically or from birth onwards their connective tissues may be weak. Weakened connective tissues will be there. The tissues which are supplying the uterus are weak, so there is a chance for inversion or it loosening, and that may lead to the inversion of the uterus. And the next one is mismanagement of the third stage of the labor. We know that third stage means it is the delivery of the placenta. For the delivery of the placenta, actually you are supposed to take a wait and watch policy. Normally you should wait for the separation of the placenta. But here, without waiting, if you are just applying pull on the cord before the separation of the placenta, and if the uterus is not contracted, there is a chance for inversion of the uterus. And another one is Creed's expression. That is, manually you are trying to separate the placenta in the case of adhered placenta and when the uterus is relaxed. See, whenever you are trying to remove the placenta, you should make sure that the uterus is contracted effectively. When during the relaxed stage of uterus, if you are trying for the separation or for the removal of the placenta, there is a chance for inversion. And another one is faulty removal of the placenta. That is, for example, if you are trying to remove when the uterus is relaxed, or if you are trying to remove the placenta before the separation of the placenta from the endometrium. These are the faulty removal. While separating the retained placenta, sometimes a portion of the placenta may get attached over there, and when you are trying to remove that portion, during that time also sometimes the same inversion may occur. Next, let us see the signs and symptoms of uterine inversion. First one, severe bleeding will occur in 94% of the cases, and the lady will be having severe abdominal pain, especially in the third stage of labor, and hypertension and bradycardia will occur. The woman will get signs of shock, and the shock will not be in dependence to the blood loss, that is neurogenic shock will occur. And the uterine fundus won't be able to palpate abdominally. Abdominally, if you are palpating, you won't be able to feel the uterine fundus. And when you are feeling at the vagina or when you are observing the vagina, you can see a mass in the vagina. And otherwise you can see a lump in the vagina. And if you're palpating the abdomen, you can feel the abdominal tenderness and sudden cardiovascular collapse also will occur. See here in this picture, you can see the prolapsed uterus outside the vagina. Next, the lady will go to a stage of shock, and the degree of shock won't be in relation to the amount of blood loss. That is, already I have told you that neurogenic shock will occur. And the woman will start to sweat, bradycardia will occur, profuse hypotension will be there, decreased blood pressure will be there. Finally, the lady will go to a stage of cardiac arrest. And severe hemorrhage also will be there later. Hypovolemic shock will occur due to the hemorrhage. Initially, neurogenic shock will occur. Later, hypovolemic shock also will occur. Next, diagnosis. Diagnosis can be done on the basis of the clinical symptoms or clinical features. First one, bleeding will be there. Next, symptoms of shock will be there. And if you are palpating per abdominally, you won't be able to feel the uterine fundus. And if you are palpating if you are doing the per vaginal examination, in case of incomplete inversion, you will be able to feel the uterine fundus in the lower segment of the uterus, and in the case of complete inversion, you will be able to feel it at the vagina during your internal examination. And differential diagnosis. Sometimes you may mistake it as uterine rupture, or you may think that it is a prolapsed uterine tumor, or sometimes you may mistake it as an endometrial polyp or growth, or sometimes you may think that succinate lobe of the placenta is getting separated and it is passing through the vagina. That is, succinate lobe, already I have told you that it is an additional lobe. Usually total 20 lobes are there in the placenta, and all these lobes will be together. And succinate lobe means one lobe will be away from the other lobes. And when the placenta is getting separated, when all the other lobes are getting separated, this succinate lobe may remain inside the uterus and it may get separated later. So you may mistake it as a succinate lobe, it is coming later. You may think like that. Next, let us see the management of uterine inversion. The uterine inversion management you can see in this diagram. First, you should resuscitate the mother. You should start the IV line. You should go for the fluid replacement. And immediately after that, you should go for the replacement of the uterus. And if you are able to replace the uterus, immediately after replacing the uterus, you just make sure, wait for the contraction. Once if the contraction has started, you can try for the removal of the placenta, and you can start oxytocin for ensuring the effective contraction, and you should give antibiotics also for prophylactically for preventing the infection. But if you are not able to replace it back, after stabilizing the patient, you can take measures for replacing the uterus back into the position. For that, manually by using the hand you can try for that. Otherwise, you can use the O'Sullivan hydrostatic method. We can see how to do the manual thing and how to do the Sullivan hydrostatic measure, that we can see in the subsequent slides. First, already I have told you that you should go for the resuscitation of the mother. You should try for replacing the uterus, and you should take measures for controlling the hemorrhage, bleeding if it is there. And if the mother is having shock, you should manage that. And if the shock is not developed, the better way to prevent the development of shock is immediately you have to replace the uterus. And when you are replacing the uterus, already I have told you that the better way for preventing the shock is replacing the uterus. And when you are replacing the uterus, the principle that you are supposed to follow is the part of the uterus which has come down last should go back first. So naturally the fundus will be coming first, and the side-lying structures, cervix, all those portions will be coming last. So those last portions you should replace first, and at last you are supposed to replace the uterine fundus. After diagnosing, naturally, immediately after the problem, immediately after the inversion, if you are diagnosing, it is easy for you, because during the process of inversion, naturally the uterus may be or will be in a relaxed stage. On that stage, if you are trying to replace the uterus, it will be easy for you, because in the relaxed stage, when the muscles are relaxed, it will be easy for you to replace the uterus back into the position. For that, first you should maintain the sterile aseptic practices, put a gloves and lubricate your hands by using antiseptic cream, and hold the uterine fundus inside your hand. I will show you the picture. See here you can just hold this is the uterine fundus here. Just hold the uterine fundus in the hand, in the cup shaped hand, and the thumb and index finger should be applied over the cervical region or over the sides. The fundus is inside the cup shaped portion of the hand, and by applying upward pressure, by holding the fundus inside the hand, by applying upward pressure by using the thumb and index finger, manually you can just replace it upward. And once if it has replaced upward, by using the fist of the hand, you should apply pressure, upward pressure over the uterus for few seconds or till the next contraction of the uterus. Like this you have to apply pressure, and this hand you should keep inside the uterus till the uterus is getting contracted. And sustained pressure, that pressure should be applied for 3 to 5 minutes to achieve the complete replacement. At the same time, by using the other hand per abdominally, if you want, you can apply counter support also, and give 1 dose of oxytocin that will produce the uterine contraction. And once if the uterus is contracted and if the placenta is not separated, you can manually separate the placenta. And till the contraction of the uterus, you are not supposed to release that hand. Once if the placenta is attached, remove the placenta after the uterine contraction and after replacing the uterus. And if the placenta is partially attached, you can remove it before the replacement of the uterus. Next is bimanual compression. After replacing, by using 2 hands, one hand over the abdomen, one hand through the vagina, by using these 2 hands, you can apply pressure over the uterus. This bimanual compression will help for retaining the removing the retained bits or products of conception which is there inside the uterus, and it will stimulate the uterine contraction also. This bimanual contraction will stimulate the uterine contraction, and at the same time it helps for expelling the contents of the uterus. And if the placenta is not separated, I told you that after replacing the uterus, you should go for the separation of the placenta. How to do that means, the examiner should insert one hand into the uterus through the sides of the placenta. See, through the sides of the placenta, the fingers you can insert like this. This is the placenta. The placenta was attached here. And by the slicing movements of the hand, by the slicing, see, by this type of movement, by the slicing movement of the hand, you can separate the placenta. Slowly you can separate the placenta, and once if it has fully separated, you can go for the placenta delivery. And the O'Sullivan's hydrostatic method is, we are supposed to insert a tube into the posterior fornices of the vagina, and through that tube you can fill the uterus with water, with saline water, sterile saline solution you can use for that. And when the amount of solution inside the uterus is increasing, naturally the pressure inside the uterine cavity will increase, and that pressure will restore the position of the uterus, or it will just inflate the uterus as like a balloon, or it will help for the upward displacement of the uterus. And for keeping the solution inside, by using an assistant can cover the vagina. See, here the solution is going and the assistant is covering the vagina in order to prevent the leaking of the fluid. This is the method. Another one is, instead of using that method for covering the vagina, you can use the cup of a vacuum extractor. Vacuum cup you can apply over the vagina. It will just seal the vagina perfectly. Instead of the hand, you are just using the cup. And same way you can just fill the uterus with the fluid. Once if the fluid is filled over there, just cover the uterus, cover the vagina by using the cup, and it will help for remaining the pressure. It will help for the retention of the, see, here the fluid is going inside and it is helping for the upward displacement or It is helping for making the uterus to the bringing the uterus to the normal position, and here it is sealed with the cup. See, exactly, you can see here the cup is attached to the portion of the uterus where it was separated. Naturally, slowly the fluid will get filled into the cavity. Finally, it will seal over the vagina. Next, if all these measures fails, manual method and even your Sullivan's method, everything is failed, what you can do means you can go for the hysterectomy, that is the removal of the uterus. You can do the hysterectomy if the conservative methods, all the conservative measures fails, and if the family is completed, if the woman don't want to have the further children, if they are having 2 children in that cases, or if the woman is having severe infection, in those cases you can go for the hysterectomy or for the removal of the uterus. And for preventing the inversion of the uterus, what you can do means you should not apply excessive traction on the umbilical cord, and you should not apply excessive pressure over the uterine fundus during the process of labor, and you should avoid the measures that are increasing the intra-abdominal pressure. For example, if the mother is having severe cough, you can give the medicines for controlling that, and you should not go for the vigorous manual removal of the placenta. Now let us see how to prevent the uterine inversion. The same measures already what I have told that you should avoid, that will help for the prevention. Along with that, the placenta you should not try to expel when the uterus is relaxed, that already I have told you. And once after the uterus is replaced, you should not allow the woman to change the position, and you should not pull the cord simultaneously with the fundal pressure. That is, when you are trying for removal of the placenta, when you are pulling over the cord, you should not apply pressure over the uterine fundus, because pulling and upward pressure, both these things, if you are applying at the same time, that may lead to the inversion of the uterus. And when you are trying for the manual removal of the placenta, you should do it properly. You should make sure that you are not applying excessive pressure. You should make sure that you are not applying fundal pressure, and you should make sure that the uterus is contracted effectively. Then only you should try for the manual removal of the placenta. Thank you for watching my presentation. If you like this video, please subscribe my channel. Thank you.